Welcome everybody to this session, Intravascular Lithotripsy in the Real World. The revolution continues. I think we're going to have an interesting session talking about how the use of lithotripsy has evolved in these 5 years, and also with some very interesting real-world data from registries. So these are my disclosures. The objective of the session today is to understand how IVL in clinical practice has evolved over the last 5 years, to learn how clinical scenarios are influenced by and supported by the clinical evidence, and evaluate the effects of IVL in different patterns of calcific coronary disease. Please feel free to come to the microphone to ask your questions. This is really important in this session. Your interaction and all your questions are important. So please go to the microphone every time you have a burning question. So we have Dr. Javier Escanet from Madrid, Dr. Siad Ali from New York, Dr. Thit from Santiago in Spain, and Dr. Ashok Seth from India. This is going to be they're going to be our speakers for this session today. So first, I have the pleasure to introduce Javier Escanet. His talk is a personal journey with IVL, the Madrid experience. Javier, please.
Thank you very much, Nieves. Thank you very much for reporting an experience of which you are a very important part of. So we had our first experience with this technology in 2018. Up to now, we have performed something like 240 IVL procedures, and we have leaded or participated in 15 publications on IVL indexing PubMed up to date. We also have 12 live case transmissions that I've been able to trace, and I thought that it was a good idea to come back to our experience and to think of how does IVL works. These are the questions that we had in 2018. What were the long-term results, to know if it is equally effective in different calcification patterns, and also if IVL can be used in truly challenging scenarios. These were the questions that we had at that time. And this was the first live case transmission made in EuroPCR. There was another one from Toulouse in 2018, where we were able to demonstrate in this patient with the last remaining vessel the effect of these very important cracks in the plaque when you are performing the intervention. You see that the patient is on intra-aortic balloon pump. We could not use Impella in this particular patient, and the patient was successfully treated. So the question we had at that time is, what is the meaning of these cracks that we have in the vessel? I mean, we knew that, that when you use a high-pressure balloon, a non-compliant balloon, and you make ruptures in the external elastic lamina, this is followed in many occasions by extensive aggressive restenosis. So the same happened in these particular patients. And that drives us to actually follow our patients and other hospitals in Spain in the long term to perform OCT, and then we could see that actually the results were quite good in the long term, both in terms of minimal luminal diameter and percentage stenosis. So it looked like the healing was good. And as a matter of fact, this is the same patient that was followed 28 months later, and you can see that all these cracks that were produced at the time of IVL were now nicely sealed by an even round area of neointimal hyperplasia, but there was no problem. In 2019, we performed the first live case known of rotashock during a live case. It was this type of, I would say, a monster of calcification, and which, some of the colleagues say you should not go live with this case. But we say, well, we are trying to share what we do in our real practice. And it was really difficult to negotiate even a wire. We needed to do this. It was Nieves and myself, and it would be impossible to negotiate the IVL balloon without doing rotational atherectomy. As you can see this, you can see here. And after performing rotational atherectomy in the case, we went with shockwave. We used different sizes of balloons, of course, and we were very happy to see that actually this very nasty, I would say, nodular calcium that was there was really being relieved, and that actually was followed by a good result. This was one of the first cases where in EuroPCR they were using also something that we developed in Madrid, that was the interactive screens. So the case was extensively discussed by Thierry Lefebvre. You can see here the effect that it has on this nodular calcium. And in the meantime, you know, what we did is completing the case with the stents. Here you see Thierry at that time explaining how the case was being performed to achieve this result, which I feel that we all agree this is quite good for the time of aggressive calcification that you have in this type of vessels. So if you're interested to see this case, you can scan the QR code and you can see the whole thing. There are many other tips and tricks that I think are interesting to share. But the question that we had at that time is saying, gosh, so can we use IVL to treat this type of very heavy nodular calcium, or in general eccentric calcification compared to concentric? And that's what we did also with our fellow and now consultant cardiologist in Ireland, Angela McInerney. The idea was to check what was the result of IVL and stenting in patients who had eccentric or concentric calcification as measured with OCT, and we also found that there was no difference between the two. So it's very, so to speak, a very reassuring message regarding the fact that IVL can also work in the context of eccentric calcification. Now, if you're interested also in the experience of RotaShock, this has been put together by Gennaro Sardella just a few days ago. It was published online, and you can access also using this code that you have there. Now, there are very few times in a professional life when you can impress Professor Bramwell, and I had my chance in 2018 in this particular session, and so he was really interested in seeing this new technique that was called IVL, that he was not much aware of it. The case was rather challenging. It's a 92-year-old lady, again a case that was presented at the EuroPCR, at the ESC conference. Huge calcification, concentric, left main, very challenging. The way that it was resolved was treated first with large balloons sized based on intracoronary imaging. You can see here that they were very resistive at the beginning to the first delivery of energy, but little by little they were improving. And the case was completed by performing tap technique to the LAD that you can see here and obtaining a very good result. Again, demonstrating that this technique of plaque modification can be used in very challenging cases where you have affectation, when the left main coronary artery disease is involved. And you will see now the final result, I believe, after the IVUS results. We typically use OCT or IVUS to guide these procedures. And let me see if I can show you the final result, so you can have a look. Okay, so sorry about that. Let me see if I'll try to go to the final result if I can. Probably there. I don't think I will be able to, but anyway, it will be nice if you can see it, because it's. So this is the final result that you can see here. So subsequently, what we did is we led a registry on the use of IVL in the left main that you can also access with this QR code that demonstrated that this is a safe approach and actually quite effective. And we have many colleagues from Europe joining this Madrid-led registry. So my final remarks is that over the last 5 years in our IVL journey, we had the opportunity to find reassuring answers to some of the initial questions that we had in 2018. And we have found that alone or in combination with other plaque preparation techniques, IVL has greatly contributed to more effective and potentially safer interventions in complex patients undergoing PCI. Thank you for your attention.
Thank you very much, Javier. I have a question, Javier. So, I mean, looking back at these live cases, it's interesting because from the beginning we were using it for all types of calcium. So I don't know, at a certain point, this idea of is only for concentric calcium and not for nodular calcium, but from the beginning we were using it really for all types of calcium. Imagine this nodular calcification that required actually a combination of techniques, no? But we didn't have this idea of it doesn't work in calcium nodules, no? From the beginning we thought it could could work there, because that was the experience, no? What do you think?
Absolutely, and we also were not looking to the thickness of calcium. I mean, we had some, we were told that if the thickness of calcium was more than 1 millimeter, then you might have lots of resistance and difficulties, which, by the way, probably have been circumvented now by the new generation of IVL balloons that can deliver up to 120 hits during the procedure. But it's true that, Nieves, what is very reassuring is that the data that we obtained is quite concordant with the data that comes from other studies, like the DisruptCat series of studies, and the data that has been published by other colleagues.
There's
some colleague in the...
Professor, you've done hundreds of cases. I did like 20, 25 cases. And I can't believe that such a good thing, there must be some evil to it as well. There must be something negative about it. I'm struggling to find a problem in it. So I wonder if you've come across...
I cannot hear you.
There must be something negative about it. I mean, I personally, in my personal experience, I have never come across anything as good as this. But have you come across in your 230 cases that it was counterproductive, or...
I think it's very good that you have concerns about the safety. I think that the way that demonstrating that a technique is safe is not assuming that it is safe, but challenging it. So is really, really good, and I echo your concern. The good thing is that so far we have not been able to demonstrate that that's the case. So that's something that, of course, we will need to continue following this. But in principle, I think that the fact that you improve the plasticity of these calcium chunks is followed by less damage to the vessel when you inflate the non-compliant balloon or you implant the stent. This is my impression. And if you look to these pathological studies from Rino Birmani, what you see in people that have been treating with other methods in calcific stenosis is sometimes quite disturbing, actually, in terms of the vascular response that you have.
Yeah, actually, the angiographic follow-up study that we did, and also with OCT, was quite reassuring, also in this, because it's true that you make these big fractures, and we were a bit concerned about what could be the response to this. There can be restenosis in the future, even when the data was good from the clinical point of view, but we thought it was needed some angiographic data and OCT data, and the data is quite reassuring, as you showed in this paper we published. Thank you very much, Javier. So maybe we can continue now with Siad, that is going to tell us about the mechanisms of IVL and the fractures by histology, OCT, and micro-CT. Siad, please.
Thank you. Okay, so I sort of retitled my talk here, which is Expansion Without Fracture, Seeing is Believing. So I should give credit to Alok Finn and Renu Vermani, who did a lot of these experiments. My disclosure is I helped develop this technology, so I do hold some equity. Okay, so you kind of all know about the mechanism by which shockwave works, right? It creates a vapor bubble. The vapor bubble comes and shoots out of these emitters, out of these small holes, and those small holes then provide a huge amount of energy without dilation over a very short period of time. So you've probably heard me talk about this before. It's like a karate chop. It's extremely powerful, it's extremely short-lived, and it provides a huge amount of energy, and that's how you get a fracture. So back in 2014, when we started these very, very original experiments, we were using IVUS. And I remember when we were doing the original GLP experiments, I said we should use OCT, and they said, what's that? And we then put the OCT and the IVUS together and realized, and made the company realize when we were doing the experiments, that the resolution of OCT, particularly in calcium, provides a lot of advantage, because we might be able to see things that we cannot see by IVUS. Because, of course, sound cannot penetrate through calcium. All of you are familiar with these type of pictures. Calcium is a crystal, light will shine through it, so we get the arc, we get the thickness, and we get the length. And so it makes it very, very easy to not only assess burden of calcification, but the modification of calcification. We published almost 5 years ago this rule of fives that says if you have a calcium arc of more than 50%, it's 5 millimeters long and 0.5 millimeters thick, i.e. the rule of fives, you need to think of advanced lesion preparation because a simple balloon won't work. And that's sort of the algorithm that we made. And we showed that as you get to moderate to severe calcification on angio, that we started to need to think of more advanced lesion preparation, of which, of course, IVL is a major component. So what did we learn over these years? We learned categorically that the mechanism by which IVL works and improves compliance is by fracturing calcium. And you're all used to these linear pictures. In fact, in the first ever paper of IVL, when it used to be called lithoplasty, the reviewer really gave me a hard time because they'd never seen these box patterns before, and they said, please stop sending OCT images with artifact on it. So we actually published and sent all 375 frames of the OCT back to the reviewer. He then wrote the editorial and took the credit for it. So what do we know by the OCT? So in the OCT sub-studies, we see that you have a tight lesion, you fracture the calcium, that improves the lumen area a little bit, so we got our compliance back, and then we put a stent in, and then we get a very good acute luminal gain over time. And this is kind of the typical pattern that we see from pre-procedure, post-IVL, and then post-stent, moving these tectonic plates away from each other, the stent pushing these plates away, and then letting the vessel heal. And over again, we showed the same thing. Multiple studies showed that lots of fractures, lots of luminal gain. This was like my children getting along. I loved IVL. I love OCT. It was a perfect marriage. And then we learned that most of the patients were getting multiple fractures, or the NC balloons usually get one fracture because it'll fracture at the point of least resistance. That fits with the mechanism of action because, of course, IVL doesn't care which way the energy goes. Comes out of the balloon circumferentially. It has no bias. Wherever there's calcium, it'll work on it. If you only have 90 degrees, it'll work on 90 degrees. If it has 180 degrees, it'll work on 180, and so on. But then this paper came out, which of course is the seminal, the US pivotal study, Lithotripsy 83, and it says that whether you had fractures or no fractures, you got the same stent expansion, minimal stent area, and area stenosis. And I remember my friend Isaac Zacharias and I were talking about this, and how do you say this in French? I said this was le bullshit, right? I said, that doesn't make any sense. How is that possible? If the mechanism of IVL is to create calcium fracture, and there's no fracture, how are they getting the same expansion? And then we came across this picture, okay? So this is an experiment that Renew did where we shock waved basically cadaver arteries and found out that unlike an NC balloon, which really fractures in one plane, x-axis or y-axis, the IVL creates chips and cracks all over the place, X, Y, Z. So it's really kind of crumbling the pavement instead of just cracking the pavement. But this image taught us a lot because on the micro CT, there's a fracture, but on the OCT, you can't see it. And so the scientist in me said, well, something's up with this because maybe what's happening is we're not able to see the fractures. And so credit to Shockwave because they actually wanted to prove this. They hired the right people to do it. This is work from CVPath. And basically in 15 cadaver lesions, what we did is we did histology, OCT, and micro CT on all the patients, okay? I shouldn't say patients, I should say all the hearts. Patients are gone. So what you'll notice is the maximum degree of arc here is about 140 degrees. Keep in mind because it does pay particular sort of attention to how we think this would translate to the patients that we're actually treating. All right, so how do we do it? So what you do is you take an X-ray of the heart, so you can map everywhere the calcium is. You then cut the arteries out. You then treat them either with a balloon or with IVL, and then you send them to the micro CT scanner. Then you come back, you image them with the OCT. Then you embed them into this plasticizing resin, and then you cut them with a diamond tip saw. So if you don't do that, of course, if you slide a microtome or a knife through a calcified vessel, it'll just destroy the artery. So in order to be able to see the fractures, you got to embed it in this plasticizing resin. And so we had these co-registered pre and post-treatment cross-sections of the CT, the OCT, and the histology in both groups. And what you can see in the plain old balloon angioplasty is this is an eccentric lesion. You get a dissection because you get a tear at the fibrocalcific interface, but you see also the typical pattern that we're used to, a nice big fracture on CT and a nice big fracture on OCT. But here's what we were waiting for, that OCT actually might underestimate calcium fracture presence and depth, and that's because the linear pattern of OCT, right? So light comes out in a linear pattern and reflects in a linear pattern. And unless you have the perfect shape, there will be situations where the light does not penetrate and create any refraction inside a crystal. So imagine you crack a crystal and the plates don't move away from each other. You could shine a light through it and you'd have no change in refraction. That's actually what's happening. So you can see here a full thickness fracture on CT, a full thickness fracture on histology, but a very small crack on the OCT. And actually this proves to be quite common. So it turns out that almost half of fractures that are identified on micro-CT are completely missed by OCT. So what that really means is that whether or not you have fractures on the OCT should not be the be-all and end-all of whether your lesion is prepared. What that means clinically is that if you see fractures, it certainly gives you a very, very good sense of security that the stent is going to be able to expand. But if you don't see the fractures and you do see your balloon expand in two different angles beautifully, it is likely that you have still improved the compliance, I'm going to say almost certainly, and that you should be able to put in your stent. And here's another example of where the micro-CT has a complete fracture and the OCT, it's very, very difficult to see, and the histology, again, shows a fracture. Just in terms of correlation, you can see that micro-CT and histology are very, very close, but OCT misses about 50% of these fractures. So in this important ex vivo study, the first histological examination to compare the two, you can see that IVL treatment demonstrates histologically more calcium fracture compared to POBA. So in the 14 cases that were analyzed, 13 had a fracture. They were identified by the CT, and that OCT probably underestimates the presence of calcium fracture and calcium depth. Thank you very much.
Thank you, Siad, because I think this is actually also what we see in clinical practice. No? So you could see some cases you couldn't see fractures, but still the balloon expanded well and the stent expanded well. If you want, Siad, maybe we can make the questions at the end,
yeah,
because
sure.
we are a bit late in the, and then we can make some questions on the end. So I'm going to invite now Belén, Doctora Belén Cid from Santiago in Spain, and she's going to present the results of the Spanish registry.
Okay, thank you, Nieves, and thank you so much for the invitation to participate in this session. In the next few minutes, we are going to review the role of IVL in a real-world patient through the findings of the Spanish registry replica. We all know that IVLs really change the treatment of calcified coronary lesions, and the pooled data of the DISRUPT study has shown an excellent angiographic and clinical results. However, they are limited by a highly selected population. So in this scenario, the replica EPIC-18 is a multi-center all-comers study designed to assess the effectiveness and safety of IVL to treat calcified coronary lesions in a real-life unselected cohort of consecutive patients. Our primary effectiveness endpoint was procedural success, defined as a successful PCI with less than 20% of residual stenosis and without hospital MACE. And our safety primary endpoint was incidence of MACE and 30 days and a year. As an all-comers, the only exclusion criteria was hemodynamic instability with KLIP class 3 or 4. And we enrolled 426 patients in 26 hospitals in Spain. IVL therapy was not possible only in 4 patients, and 3 of them due to balloon crossing failure. And if we look at the baseline characteristics, the first thing to notice is that these are really high-risk patients with a high proportion of diabetes, almost 20% of heart failure and admission, and 4% of patients were treated under hemodynamic support. But it's important, and I want to highlight the high percentage of acute coronary syndrome. As you can see, 63% of our patients. And what kind of lesions do we treat in our daily practice? Again, high-risk lesions excluded from the disrupt studies. Left main coronary artery in 11%, chronic total occlusion, angiographic thrombus. And it's important to know that 41% of lesions were considered undilatable lesions. As you can see, we only treat with direct IVL 10%, so in our real practice, we combine techniques. And in our experience, we mostly use NC balloon or high-pressure cutting balloon, but I want to highlight that 12% of rotatripsy and even some orbital and laser. Almost half of the procedures were guided by intracoronary imaging, as you can see, IVUS and OCT. And if we look at the results at the primary endpoint, more than 90% of patients had a successful procedure with residual stenosis less than 20% and without in-hospital MACE. Here I show you the core lab QCA analysis data. You can see the liminal gain and the change in the diameter of stenosis, baseline post-IVL, and the final result after stent. At PCR, we presented our results at 1 year follow-up. And the results in terms of MACE, MI, ischemia driving target vessel revascularization, and thrombosis are very good, considering that these are very high-risk patients. We observed an unexpected number of non-cardiovascular deaths. Finally, another important point was that we asked the operators their subjective impression about the impact of IVL on PCI outcomes. And most of them, as you can see, thought that IVL made the procedure easier, or the procedure would have been impossible without IVL. In conclusion, coronary IVL is a safe procedure and effectively facilitates stent implantation in severely calcified lesions in a real-life setting, and PCI with IVL in selected high-risk patients show low incidence of MACE at 12 months follow-up. So congratulations to all the replica investigators, and thank you very much for your attention.
Thank you very much, Belén. I don't know if you have any question from the audience. So I think what is important from this type of data, I don't know if you agree, Siad, is that this is real-world data, and these are, it's super high-risk patients.
What we know is that all of the calcium modalities work on calcium, whether you use atherectomy, whether it's orbital, rota, or IVL. But the differentiator is the safety. So if you do, in Disrupt CAD series, you have 561 patients. There's no reflow. There's no slow flow. There's one perforation which happened after the NC balloon. The safety of this device is what makes it so unique. So, the question that came back, is there too much of a good thing? Not right now. I mean, this is the answer to what we were having trouble with before.
Congratulations, Zita. It was very impressive speech. I would like to make a question to Zita, to all the panel.
Yeah, of course.
What do you think about the possibility to increase a little bit the indication for IVL? I mean, Zita presented a slide with the no calcium, mild and moderate calcium cutting balloon, and massive calcium IVL. I think that if you make angio, you have 30% of calcium. If you make OCT, you can have 60% of calcium. If you make CT, you can have 80% of calcium. thus I think that we cannot base our choice only on angio-coro, but we have to make at least one imaging to know if the calcium burden is very high. But you don't think that it's better in this moment, in this point, with this device, that it's very easy. It doesn't need a learning curve. It's not like rotablators, like not orbita, and the operators, maybe the majority of operators that are very lazy, they are not afraid about this. To avoid to start with a cutting balloon or with the other balloon, I don't remember the name, okay,
balloon,
this high pressure balloon, and to start with shockwave, even in mild and moderate, because we know that if a mild and moderate in angio, it's more than mild and moderate. What do you think about?
Well, if you look at, say, we did a study of 500 patients where we did OCT, IVUS, and angiography. And OCT and IVUS are very sensitive to pick up calcium. And angio in that group is about 40%. But only the angiographically moderate to severe calcifications were related to stent under expansion, which is why we drew the line at moderate to severe calcification on the angio and not on the OCT and IVUS. To answer your question, if there was no implications on finance, there's no implications on deliverability, which are very small, yeah, absolutely. It works. This works. It doesn't matter if it's got 10 degrees, 90 degrees, 180 degrees, or 360 degrees. If the balloon and the energy interact with calcium, it will break it. And it probably does something else called debonding. So debonding is when you break calcium and the interface on the back wall of the calcium and the tissue releases, kind of like peeling off a scab. So that's another mechanism by which we can improve compliance.
I also want to add that you must keep in mind that it's a great device. It actually delivers. There's still the deliverability issues which will come forth and which will get better. You have multi-vessel disease and you're rationing pulses. So there are limitations to the device which are being corrected. And therefore, when you put eggs in all the eggs in the same basket, you start finding there are advantages of one over the other and limitations of one over the other. And how do we combine it to get the best MSAs is the real answer. And that's why we have these devices to use ourselves rather than a single device for everything that we have in our.
Thank you, Asoko. So maybe you can,
Sure.
Well, we answer this last question from the audience.
So in some of the cases, they always easy to pass this device because sometimes they say you will have to do a pre-dilatation. So I had a case in very proximal LAD, very similar to your left main, and where we could not advance the device, and we have to do a pre-dilatation. Is it routinely recommended, or or you don't need it?
Personally, we think pre-dilatation is a good idea. If you can't get the device across, it's not a great idea to shove the device across. Pre-dilatation adds on advantages of giving the balloon the space to expand and be opposed to the vessel wall rather than the emitters fire on a constrained balloon. And practically, you therefore get the balloon closer to the calcium that you want to break. So pre-dilatation is a good idea rather than shoving the balloon through tight, tortuous anatomies.
So that's
Thank
one
you.
of the disadvantage, negative point, what we are talking about.
Yeah, for our colleague there. So
I'm going to talk
Let me
about.
introduce you, Dr. Shev. Let me introduce you.
Okay.
So we have the pleasure of inviting here Dr. Shev. He's going to talk about the role of combination therapies. We have been talking about it, but he's going to talk about the role of combination therapies in real world and in India. Tell us.
So we've heard enough about a lot about the science and the efficacy of IVL, my conflicts. Now, this is the real world. Majority of these patients were actually excluded from the DisruptCat data. You have this massive calcification. I don't even call it severe. Massive calcification, nodular calcification. You have calcified CTOs. You got this left main rough bifurcations. These are treacherous lesions, and you got 2 layers of a stent with a sandwich of calcification in between, and that's what you present to you in your daily careers. variety of devices available to us. I think we must remember that IVL is safe. We've talked about that. It's effective. It's an extremely user-friendly device for the treatment of severely calcified lesions. But let's also understand that, and give due credit to other devices as well. Each device has its unique modes of action and calcium modification with advantages and limitations, and there are some limitations of IVL as well. So clearly in the real world, treacherous cases with calcified lesions with massive calcium burden, device synergy is a logical concept which aims at combining the advantages of various devices for more effective and safer calcium modification. And the final answer is that we need to achieve the largest MSAs possible with safety. So of course we understand that the commonest device synergy is a rototripsy, combination of rotational atherectomy or any atherectomy followed by IVL. But we must understand that quite a lot of this rototripsy comes out of the fact that there is no other way to do it. You've got a balloon uncrossable lesion, you actually have to go in there, rotablate it, and start getting your IVL across. If you have primarily done a rotational atherectomy and there are areas which don't open up with a balloon, you have a fallback option about IVL, and these are just obvious ones. But what about upfront rototripsy? Does that have a role at all? Or the fact that you can actually still cross that lesion, and that's the concept of calcium volume reduction followed by calcium fracture, an unproven concept, but on imaging seems to be a very attractive hypothesis, which should certainly be put into more randomized trials. But to tell you frankly, every adjunctive device, or what I call device synergy, has in it IVL as the main tool, with others being adjunctive, to promote the efficiency of IVL. And I can discuss what I mean by promoting efficiency of IVL. And that is, of course, for long calcified lesions. We have these eccentric and nodular calciums. We have large vessels and tapering vessels with heavy calcium burden, in which device synergy can actually be advantageous for IVL to be more efficient. We must remember that IVL is a rationed device. It has 80 pulses. It's now going to have 120 pulses. But it's not innumerable, an indefinite number of pulses or inflations that you can do. And of course, we can always discuss about my other device synergy, IVL plus OP and ultra high pressure, which always has to be image guided, which is also only to get larger MSAs. And we can discuss when, why, and where. So let's now get on to the fact that, of course, in the I launched IVL in January of 2020, which is now 3.5 years ago. And this is my experience of the last 1 year, post-COVID, as the COVID was sort of regressing. I did close to 800 PCIs personally. And out of this was 16% of these were heavily calcified lesions. So we're not talking about moderate or severe, we're talking about heavily calcified lesions. 30% of them are device synergy. And that's what this shows, 30% device synergy, of which 20% is rototripsy. So let's move on to this elegant demonstration of why device synergy can actually work. So this is a long calcified lesion. You can see at the point around here is a heavily eccentric calcified lesion. Obviously, imaging catheter would not cross this balloon. Yes, it could perhaps if I shoved and pushed hard, but then there's no reason to shove and push hard. So you then go on to burring it. And after rotational atherectomy, the images demonstrate excellent grooving of that thick eccentric calcium right at that point. And that groove is you can just imagine how a balloon would now, IVL balloon would sit into that groove and try and crack that calcium, which is usually, it requires multiple pulses. And when you're faced with this long lesion, you want to know where to give your maximum pulses. The imaging relates to where should I give my maximum pulses, because the pulses are rationed. And of course, this is after a 3 millimeter IVL all across, and you can actually see now that we have fractures right at that thick calcium plate, because that's the groove, that's where the balloon sat close to the calcium and actually gave those cracks into. And of course, once you have implanted the stent, done your high pressure dilatations, you actually not just have large lumen areas, which increase after the IVL from a 4.5 now to 7.64, but you also have a circumferential expansion of the vessel. And of course, great result all over. But let me take you through some real life examples of what we have to do. So 80-year-old male, massive calcium, triple vessel and left main bifurcation disease, ejection fractions down to 30%, recurrent LVF. PA pressures are 50 at the time, and the systolic aortic pressures are at 110. PA stats are going down at 45%. Clearly, creatinine clearance is 45. So these are ultra low contrast PCIs, but they also supported PCIs. And you can see that heavy chunk of calcification. That's his vessel here. And when I see this, I actually would rotablate it straight up front. And that's because there's actually eccentric and nodular calcium right in the beginning. You have a long lesion. I'd actually just rely on the rotational atherectomy for the distal part of the LAD. I will actually size my IVL to the proximal part of the LAD and to the left main, and I therefore actually optimize the role of IVL in my practice. Having said all this, let's move over to the right, which is heavily calcified, but of course, on IVUS examination, shows me that I don't need to do any more calcium modification apart from IVL alone, and therefore it's IVL followed by high pressure inflations, which takes care of the RCA with excellent IVUS demonstrated MSAs. And then, of course, you move over to the left system, and this is all an impeller support, as you can see. Rotational atherectomy down right to the distal LAD, to the distal end of the LAD. Then you just put a stent, NC balloon and stent to the distal part of the LAD. You're then able to do the circumflex and then, of course, get down to the business of IVL, which is now a 4 millimeter IVL, rather than take a 3 or 3 and try to match it to the proximal left main, etc. Do the proximal LAD in the left main with give 60 pulses, add that eccentric heavy calcified lesion, deliver the pulses, and you can see that giving way another 20 pulses to the ostia, do a double kiss crush, and then, of course, you have a perfect result on what was an ugly-looking lesion with a combination therapies. And these are possible with combination therapies, perhaps. Of course, these need to be proven, but look at the sort of osteas that you get. I may just dwell on an example, and I'll be brief around this. Nodular calcification in a guy who's 45 years old. And he also has a calcified CTO, attempted twice at another center, creating dissections, which had to then heal up and then brought to the cath lab. It's also anomalous. When you face these lesions, of course, you are bound by the fact that, firstly, crossing that CTO is not going to be easy. Guy had 3 small balloons, somehow managed to get a microcatheter wedged in. Finally, some balloons actually managed to cross it, dilate it, get a wire across, get a rotor wire across. And of course, through the extension catheter, then one is able to rotablate it. After rotational atherectomy through the guide extension catheter, you actually then have the imaging ability, and the imaging ability then demonstrates to you that you got massive calcification right at that point of a total occlusion. And that's circumferential, real thick calcification. You take an IVL down, deliver your 60 pulses, keep the 20 for the other. You could actually use 2 IVLs if your hospital patients allowed it, third-party payer allowed it. But then this is what I mean by rationing and why you need sometimes ultra-high pressure balloons also. When you ration your pulses, you may not actually get the complete dilatation. So at 60 pulses, did implant a stent, saw the MSA was not as good, put in an OPN, went up to 40 atmospheres with a 3 millimeter balloon, and then you actually have perfect result on that. The images show that you actually expanded it up to 6.5 and above, which is what you needed. And then on the other side, again, that balloon would not cross that lesion. Rotational atherectomy of that nodular calcium, saw the nodular calcium on the OCT, and of course you then have an IVL, deliver your pulses, and of course do the job with great result. I want to tell you about the Shock India registry, make you aware of that. This is the world's largest registry of IVL in real-world all-comer patients. 1,000 patients are being enrolled, and this registry would finish in a month's time. I am privileged to be the principal investigator of this. This is core lab, both for OCT, 100 OCT cases, as well as the IVL angiographic cases. The data points are the same as Disrupt CAD, so that non-CAD and CAD-like patients can actually be compared. 920 patients have already been enrolled, 100 OCT substudy has been completed, 66% diabetics, 74% hypertensives, mean length of the lesion 40, but 50 left main bifurcations, 10% cases are calcific CTOs, 116, which is 10% of these cases, are rototripsy, and 38 underexpanded in-stent restenosis. So we're looking forward to this data. We hope to be able to present it at the TCT, and stay tuned, watch that data. Thank you very much. They're the biggest registry of the world.
Thank you very much, and I'm sorry to say that we run out of time, but you can have your last question, and this will be the last question, and then after that we can summarize.
A very quick question for Ziad. So in your cadaveric experiments at the beginning of the IVL, did you try putting, just for the sake of experiment, a parallel buddy wire? Because whilst it's delivering the energy through the balloon, it might score the vessel at the same time with the buddy wire there.
So that won't work.
It won't, right?
And the reason
why?
is because you're inflating the balloon at 4 atmospheres. So
Yeah.
there's no cutting or scoring because there's no pressure. So the energy goes through the pulse wave by the cavitation bubble.
But
So
what I mean is that the wire would be sandwiched between the balloon and the vessel wall, right?
right, but it's only 4 atmospheres.
Yeah,
So-
I know, but still.
No, but right. So in order for you to create a fracture using a scoring or a like a Wolverine or a cutting balloon, you have to. It's like a butter knife. You put a butter knife on top of a plate, it won't break. You got to hit it with a hammer. Then when you hit the butter knife with the hammer, then the plate will crack. So that's just not 4 atmospheres. Just not enough energy in order for you'll get contact, but you won't break the plate.
Right, okay.
Thank you.
Cheers.
So very, because we have run really out of time, there's a lot of interest, of course. So just to summarize, I think first talk by Javier was really, really interesting to see the historic evolution in our center and how we have been widening the indications. Very interesting data from CIAT about how sometimes OCT can underestimate the number and depth of calcium, but it doesn't mean that the device didn't do any effect on the plaque. And then we have these 2 real-world registries demonstrating that actually the technique is safe and effective in high-risk patients, such as the ones we saw here, including especially ACS patients. So with that, I would like to conclude. Thank you very much, everyone, for your attention.